All right. Hi, good afternoon. Welcome to our live session. My name's Arshad Ali. I'm founder of Scottish Centre for Excellence in Dentistry, now partner of Portman Dental Care since 2009. I'm delighted to introduce my colleague Abid Faqir. Abid's been with me for many years. I've known him and his family for a long, long time. Abid graduated in 1999, membership 2002 in the Royal College of Surgeons, Masters 2003, and was one of the very first candidates for the Diploma in Implant Dentistry, RCS Edinburgh 2011. Also past president of the ADI, so he is a very experienced practitioner. He limits his work to implants and very advanced restorative dentistry. He's placed in excess of 5,000 implants, which is fantastic. So today, we've been very fortunate to watch a live case, which was a full arch, immediate loading case, which went really well indeed. So Abid, can you tell us a wee bit about the surgery today, please?
Thanks. Thank you for the very kind introduction. Welcome everyone to today's session. We've had a great morning carrying out a full arch case on a partially dentate patient who only had a few teeth left. We used fully guided procedures involving guided planning, guided placement of implants, and then pre-planned and printed temporary teeth that were fitted literally half an hour ago. And we have a very much delighted patient with, what only can be described as a change in his life. And it went very well. We've had quite a number of delegates with us who have watched the surgery, and it was very smooth.
Excellent. So tell us a bit about your journey to guided surgery. I mean, when did you first start getting involved in guided surgery?
I think we started together.
Yeah.
I think we started together 2007, is it something like that?
Probably 5 maybe, because we presented at the Las Vegas conference.
Yeah, that's right. I think you probably did the first case. Then closely followed by, we did a few more together. So we've been involved in guided surgery since 2005. And then as the software has developed, as the products have developed, as the intricacies and the finer details have improved, we've stayed in touch with the companies, helped them develop the various products, and now it's just become a mainstay of the practice. Guided surgery, primarily because the accuracy element, the predictability element, and I think is giving our patients the choice where they get a very, very accurate surgery and a great restoration.
Fantastic. So would you say it's appropriate for every case? Would you do guided for every case, or are there cases where you would go brain guided?
So, I think you have to have the ability to do brain guided, because as with any type of dentistry, it might not work out, or you might have to change to a different strategy, a different plan during the surgery. But it is very much appropriate for about 90% of the cases. Do we use it for all cases? Maybe not. Maybe some of them are simple. But I think the more you do it, the more you'll want to use the guide, because it definitely makes it predictable. It takes the guessing factor out of it. And I think in some ways it's a nicer procedure for the patient.
Mm-hmm. Now, going back to the case today, which went really well, say you had a situation then where you placed the implant in the guided position and it wasn't very stable. Do you have an ability then to modify your plan?
What you would then do in that case is probably not load the case. You would, if it wasn't stable enough, you would either bury the implant as it is or change the size of the implant. And in that case, you would probably have to move on to brain guided to change your planning. In some of the cases, especially where I'm placing multiple implants, I'll probably over-engineer the guide. So I'll add a couple of extra implants in, just in case some of the implants don't work as you want. I've then planned a few more in case we have to add different or further implants in.
Okay. And what about you mentioned the patient today was very happy, and that's a common thing you'll find after you finish your cases. Yeah. Afterwards, do you find that there's less pain, swelling, discomfort?
Yeah, so because a lot of the planning is done beforehand, because a lot of the measurements are taken beforehand, I find the surgical time is definitely reduced. The surgical flaps that we raise are also slightly reduced, and the guesswork is taken out of it. So I find the patients are probably less swollen and not as much pain, but that's not the same for every case. But I do think there is an element of better patient post-op with the guided cases.
Yeah. Okay. So the patient's got a temporary bridge today.
Yeah.
How long are you going to leave that bridge in place for?
That bridge will stay in place for 6 to 8 weeks. And there's two reasons for that. One is we want soft tissue healing. So we want as much of the recession or the change in the soft tissue volume to happen prior to us making the final bridge. And secondly, we want implants to integrate. And we have 6 weeks from the literature and the data that suggests, and with the implants we use, that 6 weeks is usually sufficient, especially where they are very stable. And then we'll start taking impressions and take the patient through the various stages to make sure they're happy with the aesthetics, happy with the bite, and we're happy with the fit before moving on to the final definitive restoration.
Right, okay. So how many, are you reducing the number of visits as well for your patients then with guided?
There is, not so much with the restorative part, because we still have to go through the various stages of making sure that the final bridge is accurate. We're still trying to make sure that the passivity of the fit is accurate, and that usually takes the same amount of visits.
Same number of visits, yeah. Okay. So you've got some delegates here today who want to get involved in this. What would your advice be to them?
I think it's the same in any type of implant dentistry. The same way our relationship started, I was referring to you in 2002, where you would put the implants in and I would restore them. I think it has to be in that way, even for full arches, where they get involved in the restorative aspects to understand where the implants need to be able to deliver the final bridge. And once they've done a few of them, they can then start to move on to planning some cases, working with an experienced clinician, and then moving on to doing the surgery themselves.
Yeah, okay. Any questions come in now? No questions come in. Okay, well, let's just carry on chatting about full arches then. So you've done an awful lot of cases, and I think it's always good also to talk about issues, problems that we've had. If you're doing any treatment, we all want all of our treatment to be 100% successful, but in clinical practice, that doesn't happen. So you can maybe share any of the issues that you may have seen over the years in relation to guided.
In relation to guided as it is, I think the issues can come about with maybe guides not fitting properly, a guide can break, the planning doesn't go as you want it to go, but usually that comes down to the design process. If a guide was to break, it's usually because it's not been bulked up enough. If it doesn't fit, maybe your initial impression wasn't accurate enough, although we are seeing with digital scanning that we don't have fit issues at all. And then the other thing is that sometimes your implant is not exactly where you want it to be. So you do have to have the ability of being able to take the guide on and off, making sure everything is as it is, because we are sometimes working in very small areas of bone where the direction of your drill or implant can inadvertently move or change. So issues can arise during the process, but I think if it's methodical, if you're watching for these things, you can pick these things up and overcome them.
Okay, well, that's good. Now, we talked about the temporary bridge work. What material was that made of?
So temporary bridge work today was PMMA. It was in acrylic. It was printed and made in one piece. We attach the implants to the temporary bridge using temporary cylinders, which are prefabricated and allow us to get that connection between the bridge and the implants.
So if you're working in a practice, we've got our own lab here, so I think some of the finishing was done in the laboratory. So if you didn't have that facility, is it easy for the surgeon the dentist to do the full
It is in full arch
case?
in full arch cases, yes. It is the case that you can finish things yourself. Mostly, I do that myself. But where there's high aesthetic demands, where maybe there's a lot of soft tissue changes that you're making, you might need a technician to modify the bridge or to make sure that the positioning is accurate enough.
Mm-hmm. And the decision on the day for loading or not loading, how would you make that decision?
That's a really good question. I mean, that depends on a number of factors. Usually, it depends on the stability of your implants. Well, my policy is to have implants more than 30 Newton centimeters in torque to get primary stability. But if I have an implant that's not a distal implant that has less than 30, I will be happily to load that as well, because in a full arch you have cross arch stabilization, so they support that implant. But it's a distal implant you need to be concerned about sometimes.
So taking things forward to the final bridge work, are there times when you'll do soft tissue surgery to improve contours? Is that something that you do often, or something that happens occasionally?
Yeah, occasionally we'll do that, but mostly the temporary prosthesis will be planned in such a way that the fitting surface allows proper cleansing, and that's you want to make sure that that fitting surface has been well designed so that your soft tissues heal in the way that you want them to look for the final prosthesis. So any soft tissue healing or adjustments or how you want to look has to happen with your temporary prosthesis.
And do you routinely graft at the time of immediate placement?
So again, yeah, good question. And although we say this is a graftless solution, it's more, I think, is more graftless solution, because we still place some types of bone graft into the extraction sockets, and sometimes around an implant which has been placed in an extraction socket, so there'll be a gap there that we'll maybe pack some bone into. Usually when there's a lot of exposed threads, we'll graft those cases, but then maybe avoid loading those cases. Yeah.
A little bit about grafting then. I mean, what's your preferred graft material? And also, what's your thoughts on PRF?
So my preferred graft material is allograft. I use Mineros a lot. It's cadaver bone and it works extremely well, I found, in my hands. We routinely use PRF, so we mix it with the patient's blood. For a couple of reasons, I find the handling improves for the graft. We also can produce membranes which can help with a little bit of soft tissue healing, especially at wound levels. But also, we have certainly seen that patients heal a little bit quicker. I think. I don't know how.
Yeah, I would concur with that.
Yeah. We've definitely found that. So PRF is definitely useful.
Excellent. And again, on to final bridge work. What materials would you prefer to use when you come to do the definitive restoration?
So about 4 years ago, I totally moved across to zirconia. So I do full arch zirconia bridges, and there's a number of reasons for that, but primarily my reason for that is that I think it's more durable. I found less wear and less chipping, as opposed to what we were using in the past, which was a titanium frame with acrylic teeth. So zirconia is our choice, either in a full arch case, or sometimes where we've got an FP1 design, we maybe even split them into smaller pieces, we will still keep it as zirconia.
So with no layering, just full zirconia?
We do a lot of full contour zirconia, but sometimes we will layer it if I want to improve on the aesthetics.
Do you think the aesthetics is improving on all zirconia now compared to, say, 5 years ago?
Yeah, it's still not as good. You're absolutely right. 5 years ago it wasn't great. It's good, but in a high aesthetic anterior case, it can be difficult to get it looking very, very natural. But I have seen it being done. Some of our technicians are fantastic, both in SCED and elsewhere, that produce beautiful results.
So I think we've got some questions coming in from the audience. So one is, will you do more live surgeries, and how do I attend?
So we've had a couple of live surgeries. We've done a single tooth immediate recently, a few months back. We've done a full arch live surgery. I think we'll keep this going every 3 to 4 months. We'll do some more. If you email into inquiry@scottishdentistry.com, they will give you future dates or keep you on the database for making those dates possible. And some more questions coming in.
There's more questions coming in. But in the meantime, I was going to ask about maintenance because, one of the biggest things in implant success, number one is, of course, your planning, your execution, your delivery of your prosthesis. But the maintenance side of things, what's your advice on that, with especially with full arch cases?
I think fundamentally our hygienists are very important in these cases, not only from the cleansability point of view, but also demonstrating to patients how to look after these bridges, using things like water picks, superfloss, and constantly maintaining the patient's hygiene every 3 months is crucial. In today's case, I used a tissue level implant. I believe either tissue level implants or implants on screw retained abutments or multi-unit abutments at tissue level is so crucial for these cases, especially from a soft tissue healing and a maintenance point of view. I don't like working at bone level in a full arch case. I think that can be open to some issues and problems.
Another question has come in. Have you found that utilising guided surgery workflow improves surgical efficiency and also the patient experience?
Yeah, I mean, I've personally found that using guided surgeries has been brilliant for the practice and for myself, because patients quickly understand that we're using cutting edge technology. They get to be very involved in the planning stage. From a consent point of view, I think is brilliant. It shows that you've checked all factors, you've taken advice on all factors, you've looked at all the different possibilities exist, and relaying these to your patient, it becomes much easier. I think the experience that the patient has with guided surgery, I also think is better, because the precision that you get is far better. I mean, I always say that, there's always that morning where you've had an argument with the wife and you're not in a great place, and you come into work and it's just nice to pick up a guide and get a little bit of help to put that implant in.
You never have arguments with your wife. Come on.
She just tells me what to do.
Absolutely. I told you that years ago. Just they're their boss. Okay. So when it comes to full arches, do you tend to stick to one implant system, or is it the case that you use a different system for different cases?
The systems that I use are Straumann, BLX and TLX. I will keep every single arch to a single system, either the BLX or TLX. But recently, most cases have been tissue level cases, unless there's a reason to make it BLX, which is bone level. And that's usually predominantly because we're angling implants. So we'll change over to a BLX in that case.
Okay. I think there's more questions coming in, but while we're waiting then, how often do you like to see the patients after treatment's completed? Have you got a guide on that?
Initially, after initial surgery, we'll see them for a 2-week review, mostly just to make sure that the healing's going in the right way. And then we'll do the impressions, as I said, at 6 weeks. After we fitted the fine restoration, we'll do an immediate visit with the hygienist. And then they're either they're definitely on a 3-month recall with a hygienist, but usually they're 6 months with ourselves.
6 months, okay. Another question, not a question. How lucky are Sked at having Dr Faqir working here? We are, of course we are. As I say, I've known this man since he was a boy. Yeah. I know his family, his parents. We go back to Pakistan, and our villages are about 2 miles apart in Pakistan. Our parents knew each other well. I know Abid's parents, and Abid I've known since he was a wee boy, a wee nipper when he couldn't hold anything. Now, I mean, I'm so happy to see where he is now, because, as he said, we started working together 2002, where he referred to me and restored. So the journey has been a long, long journey, and now I'm delighted to say he's overtaken me. Yeah. So I personally don't do full arch work now, because unfortunately, I'm not going to be around for 10, 20 years to follow these patients up and look after them. So I made a decision about 2 or 3 years ago that these big cases have to go to someone who's going to be around and be able to look after them well. So I passed my cases on to him. So yeah, we're all very lucky to have Abid here as such a skilled clinician, and not just that, just a wonderful guy, as you can see from here. So I think there's any more coming in. Goodness me, right.
There's one more last question.
I think we've covered all the ones on here, so okay, well, ladies and gentlemen, colleagues, thanks very much for dialing in today. It's been very good. I hope you've enjoyed it. I know our delegates on the day have had a great morning, and now there's some more seminars to happen in the afternoon. Abid, well done. Great case, another one. And please do keep in touch. ScottishDentistry.com is our website. We take referrals for all aspects of dentistry. We aim to see referrals within 2 weeks, and if you have patients in pain, we aim to see them on the day. So please do use us. We've got a great team of specialists and dentists with special interests, consultants, and all the specialties. And we're not only here to treat patients. If you have difficulties or wish advice or help with treatment planning, that's another aspect of our service. So I hope that we can be of help to you, and we look forward to welcoming many of you to our future courses in SCED. So thanks again for joining, and enjoy the rest of your day.
Thank you.
You.
Thank you.